Good morning, everyone. And what a beautiful place to be coming for a meeting this morning. So I think I have the easy part of the job, really talking about the clinical spectrum of Alzheimer's disease. And it's like all things, there's some new small research adding to our understanding both of the disease, its diagnosis, and hopefully its management and treatment as time goes on. But really, to understand Alzheimer's disease, we need to go back to basics. What is it? It's a progressive neurodegeneration of the brain, or a progressive brain failure. It particularly affects the part of the brain that's important for learning and storing new information. But it also affects other areas, such as language skills, so people will often have word-finding difficulty, visuospatial skills, so they may have difficulty with orientation and getting lost, things like agnosia, difficulty recognizing people, recognizing objects, executive functioning. We all do executive functioning every day without thinking about it. We get up, get out of bed, get dressed, plan our day, plan and solve issues as we go through our day, and that executive functioning can become very impaired in Alzheimer's disease. And then we can have difficulty with normal activities of daily living. So there's a spectrum of presentations for Alzheimer's disease, but as the disease progresses, you can have all of the above. And further on in the disease, you have the very difficult behavior and psychological problems associated with Alzheimer's disease, which in themselves can give us more dilemmas in their management. And what part of the brain is infected with Alzheimer's disease? Well, this is a very simple scheme, really, but there's parts of the brain that are very important for learning and remembering, and that's the hippocampus, and then the cortex, which is really here around the edge, so occipital, parietal, and frontal cortex. And the thing about Alzheimer's disease is that it's the cortex and hippocampus that's particularly affected. So I'm going to do a small little test that we often do around our kitchen table. So when we learn new information, we can learn it in a number of ways. You can hear the new information, you can see the new information, so you have different ways. So I've put 5 words up here, and I'm telling you now, I'm going to come back to them later on. So if you have a way of encoding or storing this information, now is the time to do it. So I'm going to say the words out loud: face, velvet, church, daisy, red, and you can also see them there. So when you get new information, you encode it, or you find a way of learning it, you put it into the storage box of the brain, so a bit like the hard drive of your computer, and then when required, you bring it back out again. And the trouble with Alzheimer's disease, as I say, is that you've got huge difficulty learning that information, putting it into the storage box, and getting it back out again. And that's why people will often say to me in a clinical setting, I have no problem at all remembering what I wore on my wedding day 25 years ago and who was there and the music we danced to, but I have huge problems remembering what I had for my breakfast or the conversation I had yesterday. And this again is just a schematic diagram of the atrophy that can occur in people with Alzheimer's disease compared to normal. And you can see this shrinkage all around the edge or all around the cortex, particularly in the hippocampus and parts of the brain important for language. But we also know that, yes, you have this shrinkage that occurs in the brain tissue, but long before that, you have other biochemical and other changes that are occurring within the brain. And these are really deposition of amyloid plaques. And amyloid plaques are a little bit like, and for the scientists among you, I'll have to tell you that I'm very basic in the way I speak, but very bit like insoluble large proteins. So great big lumps of stuff that shouldn't be there. That's about as basic as I can put it. And as time goes on, you have neuronal damage and these neurofibrillary tangles. So instead of having a nice clear pathway of information, a little bit like an open motorway where the pathway of information can clearly go in a nice, fast, uninterrupted way, for people with Alzheimer's disease, it's a little bit more like there's just something stopping it. That information simply won't go where it's supposed to go, which is into the storage box where you can bring it back later. So the storage box is further on here. This is the information we're trying to get in there and just simply won't go. And why are we all, as scientists and as clinicians, now so interested in Alzheimer's disease? I suppose we've always had some interest, but it was very much a neglected area for a long amount of time. And with new research and I suppose new media coverage and new interest, the amount of work being done in Alzheimer's disease is increasing exponentially, which is very exciting. But these are figures from the Alzheimer's Society in 2012, and this is really looking at the scale of the problem. So each little figure here is equivalent to 10,000 people. So I'm going to quote the UK statistics, but really they can be extrapolated to Australia and America, and I know we have people from all over the world here today. But in 2012, I beg your pardon, in 2012 or 2015 now, they reckon there's about 850,000 people in the UK with Alzheimer's disease. That's expected to increase by 2021 to over 1 million, and 2051 to 1.7 million. So the problem is huge, and the problem is huge for a number of reasons. One of the great successes of medicine is that we've increased longevity. So people are living longer now than ever before. And the greatest expansion is in the very old. So we have 25% more people aged over 80 now than we did 10 or 15 years ago. And Alzheimer's disease is very much a disease that's much more prevalent as you get older. So because we have this huge increase in the number of older people, we have a huge increase in Alzheimer's disease also. And I suppose this is the part that really the government or healthcare budget organisers need to be very aware of, is that the cost of dementia is absolutely huge. And really that's been estimated over time, because people looked at a very simple part of the cost of dementia, which is where somebody was admitted maybe to a hospital setting, forgetting that there's a huge cost in the community, a huge cost obviously in the acute hospital sector, and then a huge cost in continuing care environments such as nursing homes. And really there was huge investment in things like heart disease and cancer, rightly so. But in fact, the cost of dementia, the socio-economic burden of dementia is much more extensive. So Alzheimer's disease, we have no cure or prevention to date. And I suppose to really understand Alzheimer's disease, I think to think in a room like this that we will find the cure for Alzheimer's disease is not realistic. However, it is very realistic to assume that we can certainly significantly delay the onset of Alzheimer's disease, and that will have a huge impact both on people personally and on the socioeconomic and other burdens for society. So the treatment is aimed very much at delaying onset and slowing progression. And very exciting now, there's such an increased awareness that cardiovascular comorbidities, dietary intake, lifestyle such as smoking and drinking significantly increases your risk of Alzheimer's disease. And these do probably need to be modified before the clinical presentation of Alzheimer's disease. And we'll talk a little bit more about that as we go into the talk. So delaying here in the UK, for example, delaying the onset of Alzheimer's disease would significantly reduce mortality or death from Alzheimer's disease. We've already said the yearly cost currently is about 26 billion in the UK, but that's not taking into account the 11 billion that family carers save by actually providing care at home. 80% of people in a nursing home environment have Alzheimer's disease or some form of dementia. So Alzheimer's disease is a huge reason for people having to go into continuing care. But keep in mind though, 2/3 of people with dementia are living at home. And I'm not going to talk too much about this, but there are so many challenges with dementia and so many personal impacts, a sense of loss, isolation, loneliness, etc. And if we can in some way delay the progression or the onset of Alzheimer's disease, then that's a huge impact on people personally. And that's what we need to keep in mind, a patient-focused approach to Alzheimer's disease. So why do some people get Alzheimer's disease? Well, we know that there are definite risk factors such as genetic and familial. And I suppose right now there's maybe 40,000 younger people with Alzheimer's disease or young onset Alzheimer's disease in the UK. And familial onset Alzheimer's disease accounts for probably about 3% of the condition. Some chromosomal conditions, so we know, for example, people with Down syndrome will inevitably develop a dementia or Alzheimer's if they live long enough. And then there's your genotype being homozygous for ApoE4. Hitting your head constantly off somebody else's head is never a good idea, so repeated head injuries. And then female, smoking, all of these cardiovascular risk factors that we're really concentrating a lot more on now. Excess alcohol, maybe not a good morning to talk about that. I believe it was a great night last night, but excess alcohol and an ongoing time. And then protective. I'm a huge proponent of exercise and diet. And I really can't emphasize these enough. And this is the exciting area right now for many reasons. And I know my colleagues later on will go into this in more detail. And just keeping in mind, as I said, younger people with Alzheimer's disease, there's a great movie which I would recommend anybody who's an interested in the field to look at. But the important thing is that young onset Alzheimer's disease or familial onset will often give us more information as to how to approach this as time goes on. So the clinical timeline for Alzheimer's disease, what we now know without any doubt is that the pathology of Alzheimer's disease starts long before the clinical presentation, probably 20 years or even 30 years before the clinical presentation. So there is a prolonged preclinical stage of Alzheimer's disease where in fact memory may not be an issue at all, but there may be risk factors and other things that if you look at, and we all know these people who come to our clinics all of the time, who have very significant cardiovascular risk factors and others, maybe a family history as well, smoking, alcohol, etc. And these are people we need to identify. And now, again, we will talk about in a little while, maybe there are biomarkers and other things that will help us identify people at risk. Mild cognitive impairment, MCI or mild cognitive impairment, is a very real entity. As far as I'm concerned, there is certainly debate about it, but this is the pre-development of Alzheimer's disease. So you have people with mild cognitive impairment who can present with memory problems but are still very functionally intact. However, a significant, not all, important to say, but a significant number of these people will go on to develop Alzheimer's disease. And maybe our emphasis all along has been in treating people in this part of the disease spectrum. Whereas what we need to do is go back to mild cognitive impairment or even the preclinical stage to start altering how we treat ourselves and treat our patients at this stage to delay the onset to this part of the disease. So obviously late Alzheimer's disease is such a difficult area for people where they become very dependent in everything, and perhaps institutional care, etc. And we do have medication that we can use here to slow the progression of Alzheimer's disease. And I suppose we've medication we use here, such as treating behavioural and psychological symptoms. But it's really back at this area is where the huge excitement and research is happening now. So again, this is just saying the same thing really. With regard to this amyloid deposition, this probably starts in early 30s. But yet all of these changes, microglial activation, neurofibrillary tangles, neuronal loss, etc., starts long before the clinical presentation of Alzheimer's disease. So the diagnosis of Alzheimer's disease is very clinical for the most part. So it's based on a good clinical history and examination, story from a collateral or family member, neuropsychological testing, and I know Professor Cohen is going to speak to us about this, which is such an important clinical addition to our diagnosis of Alzheimer's disease. Evaluating functional activities, so do people have difficulty banking, shopping, all of these normal things. But this actually gives us really important information. So this part is really the important clinical bit that I do all of the time. And then these are very important additional information from the point of view of CSF biomarkers, looking at amyloid B42 and tau. Beg your pardon. There's now, I suppose, the recent Mapstone paper looking at phospholipids in blood, but this is at a very much a research part yet, EEG and neuroimaging. So neuroimaging, we have structural MRI looking at the temporal lobe and looking at the size of the hippocampus, and that can certainly give us good information with regard to the structural part of people's brain. We can look at the hypometabolism of people's brain, particularly in the hippocampus and in the cortex, again, features of MRI. And we can look at changes in function. So brain imaging, CSF measurements and biomarkers have certainly helped us be more accurate in our diagnosis of Alzheimer's disease. But the exciting thing is that a lot of these CSF findings occur much earlier in the disease. So at a pre-symptomatic somebody who is going to go on to develop Alzheimer's disease, they may well have a reduced CSF amyloid B42 at that point. The difficulty, I suppose, is that the sensitivity and specificity of biomarkers in the pre-symptomatic stage is not near as good as the sensitivity and specificity here. So we really need to take biomarkers as well as clinical presentation, as well as risk factors, as well as everything else, to try and put together a picture as to what group may go on to develop the disease. And really importantly, function. Function tends to stay very good or absolutely fine in pre-symptomatic Alzheimer's disease. And really at the end of mild cognitive people, for people who are converting to Alzheimer's disease, at this point their function goes down. So functional measurement of Alzheimer's disease in patients with Alzheimer's disease is also very important. Just very briefly talking about the brain fragility that comes with Alzheimer's disease, a little bit like a very strong elastic band. We all have elasticity of our cells all of the time. It's a little bit like a toddler falling, getting a sore knee. Their knee will be better 2 days later. I fall and have a sore knee, I have to take to bed for a week. Somebody elderly falls, I hear, my grandmother went into hospital with a hip fracture. She was never the same. I don't know what they did to her in there. But what has actually happened is that their brain is fragile and unable to cope with new insults that come along the way. So delirium or acute confusional states in people with Alzheimer's disease is very common, simply because they don't have brain reserve for additional challenges that hit you as you get older. And once you get dementia, you're more prone to delirium. Once you get delirium, you're more prone to dementia. And then people with delirium are much more likely to go to a nursing home. Why am I saying all of this? I'm saying all of this to identify that if we can stop people or delay people getting to dementia, we will also delay delirium, we will also delay discharge to nursing homes. So there is such an important impact of delaying progression of Alzheimer's disease that I think people working in the area should be very excited about. So our current management of Alzheimer's disease at the moment, obviously, and when I stand at a talk like this, I will often talk about the pharmacological impact or treatment of Alzheimer's disease. It's so much bigger than that. It's so much, things like carer support. I'm not going to talk about that, but from the very outset, that part of the management is so important. But talking a little bit about the pharmacological managements that we have at the moment, there's been no new drug for Alzheimer's disease for 10 years. So memantine, which is an NMDA receptor antagonist, was released in 2004. We're at 2015 now. And the drugs that are there very much work on the cholinesterase pathway or on glutamate. And these drugs certainly delay progression of symptoms, or they slow progression of Alzheimer's disease for a short amount of time, and they do have an impact without a doubt. But they are really licensed for people with mild to moderate Alzheimer's disease. There is of no benefit and no advantage to giving them early on in the disease or the pre-symptomatic stage. So that's what we currently have from a drug point of view. Obviously, management of risk factors is really important, and we need to do that regardless of age or time of presentation, managing hypertension, lipids, diabetes, cessation of smoking. Is it ever too late? No, it's never too late. Reduction of alcohol intake, and weight loss. That's an area that I can come back to if we have time at the end, because the whole, there's been a lot in the literature recently about BMI, raised BMI and Alzheimer's disease, and we may or may not get time to do it. Exercise, whatever your condition, exercise is really important, but certainly exercise is known to be of huge benefit in reducing cardiovascular risk factors and therefore reducing dementia. Social engagement is one of those things that maybe it all sounds a little bit woolly. It's better if you meet people more often, it will reduce your level of Alzheimer's disease. But actually, social engagement has been shown to be just as important as cholinesterase inhibitors. So actually, the people who can get a very rapid deterioration in their Alzheimer's disease are people who are living in isolation, who don't have social interaction. So social engagement as a part of Alzheimer's disease management is really important. And obviously goes without saying, support, information for carers, etc. So there's been an awful lot about diet and dietary changes for helping with the prevention, not prevention of Alzheimer's disease, but delaying progression of Alzheimer's disease. And maybe the single nutrient interventions, there's a lot of suggestion out there that diet will help. But when they actually went and looked at single nutrients, they found that single nutrients, when they researched them, didn't particularly show through in evidence that they did reduce evidence of Alzheimer's disease. And this is such a busy slide, I'm not going to talk about it in detail, but this one is more important, where there is definitely epidemiological data that shows an association between certain dietary patterns and lower risk of Alzheimer's disease. So Mediterranean diet, and the reference, everybody's welcome to a copy of the talk, references here, regular intake of fish, adherence to nutritional recommendations in middle age. Again, a very nice paper in the Journal of Clinical Nutrition, where we know that certain dietary styles will reduce the risk of Alzheimer's disease. And again, I often talk about the people in Okinawa, where islands off the coast of Japan, where they have a very strict diet, and they don't eat to excess. So hari hashabu, they stop eating when they're 2/3 full, and they have a general calorie restriction. But their diets are very high in fish and and they certainly have a very reduced incidence and prevalence of Alzheimer's disease. So the dietary part of the story is really important and very exciting. I suppose just to talk a little bit about work that we've recently done with Professor John Nolan as principal investigator and the Howard Foundation in Waterford. So what we found, and again, there's been, I know I'm speaking to experts here on age-related macular degeneration, but what we found is that there was reduced vision and reduced macular pigment in people with Alzheimer's disease. Now, the exciting part of that story for me is that in my clinical practice, I never concentrated on vision as part of my management of Alzheimer's disease. But we know that there is reduced vision and reduced carotenoids. And we then went on to do a randomized study looking at if you replace the carotenoids, do you improve vision and cognition? And these were in people with established moderate Alzheimer's disease. And what we found by replacing or giving carotenoid supplementation, that you did improve their vision. Unfortunately, you didn't improve their cognition. But remember, these are in people with established Alzheimer's disease. So there's a lot of exciting work to be done there, looking at this type of work much earlier on in the trajectory of the disease. And I know, again, I'm not going to talk because I know Liz is here and Helen Griffiths is here. There's been so much work done, and I'm going to leave them speak very eloquently about their own work, looking at this very area, at looking at carotenoids, brain function and cognition. And there's other exciting work going on as well. I know the PREVENT programme is a programme that the University of Cambridge and King's in London and elsewhere, really a multi-centre intervention programme, looking to see, can you identify people in middle age who are more likely to go on to develop Alzheimer's disease? And are there, first of all, can you identify them? And that's the conceptual programme that they're working on, to see, when can we start giving interventions. Similarly, I know pharmaceutical and clinical groups are getting together looking at European prevention of Alzheimer's disease, the EPED study. And the FINGER study is a multi-domain intervention that's being done in Sweden, or that's been published online in 2015, looking at all sorts of things like dietary intervention, exercise, etc., to see can it reduce Alzheimer's disease. And it's great, it is great now. There is so much in the media at the moment about Alzheimer's disease. It has finally taken a centre stage place, which is where it needs to be for so many reasons that I've outlined. But of course, there is always the sensational headline. So in July 2015, David Cameron, he announced a breakthrough scan to rule out Alzheimer's disease. Great. I don't know that, I think maybe that was a little bit premature. Our hope for Alzheimer's disease is researchers find licensed drugs that halt brain degeneration. Great, but I don't think that's true either. So there are sensational headlines, but maybe what we need is we do need Alzheimer's disease in the news and in people's mind so that we can highlight the extent of the problem. I want to go back for a second. So I'm not going to ask anybody in particular, do you remember the words? But we did name out 5 words earlier on in the talk. And if you can see them quickly in your mind, and then how many actually encoded them and put them into the storage box. I mentioned that we discussed this around the kitchen table with my children, and I'm fascinated that they just get it in. And half an hour later, they can regurgitate out the information. They can do this so well, whereas my husband and I struggle regularly, probably because we don't concentrate, or maybe because we're one of the ones that will go on in time. I rarely, if ever, recommend a book. This is a book that's for reading by your bedside or reading when you're relaxing. This Atul Gawande, I've never had the pleasure of meeting him. He's a surgeon, and I would have to say that surgeons wouldn't be well known for their insight into Alzheimer's disease, but he's written the most extraordinary book on being mortal and medicine and what matters in the end. And his book really highlights the degeneration of cells that happen in the body as you get older that are somewhat inevitable. So we all have a limited time span on this earth, no doubt about that. But there are interventions, without a doubt, that can make us live healthier and longer, and that's why we have these great conferences here today. Thank you.
Thank you for that uplifting on a real difficult topic. Do we have questions for Riona? Yes.
Just a short question regarding the risk factors. You mentioned that the management of the risk factors is very important, and the risk factors you listed were cardiovascular risk factors. And is there a connection between the treatment of these risk factors? So, for example, blood pressure medicine has been taken over the last 50 years to each and everyone who has a little bit higher blood pressure. So the other word is it really proven that the risk factor is a cardiovascular thing, or is a treatment, which is now a massive treatment among the population, is a risk factor?
Okay, this is a very interesting question. I suppose the first thing to say to you is that and we have got better at managing cardiovascular risk factors generally. And in fact, one of the reasons for the explosion of Alzheimer's disease is the explosion of the aging population. But per person, by managing cardiovascular risk factors, there is no doubt that we're reducing vascular disease and Alzheimer's disease. So there is no doubt about that. Your question, is it a specific intervention? Is it a specific antihypertensive medication that's actually reducing the risk? That part I can't tell you. And I know that there's huge studies going on, like the NILVAD study, for example, looking at a specific antihypertensive to see, is it the drug? Is it management of the condition, or is it overall making people healthier that's reducing the disease? Does that answer your question?
Can you speak to the role of inflammation in the etiology of Alzheimer's?
I am going to leave that to my learned colleagues, because I know Professor Griffiths is going to speak about, I hope is going to speak about antioxidation and inflammation. You know, I suppose there has been studies done looking, for example, at anti-inflammatories, and do anti-inflammatories, for example, giving diclofenac or anti-inflammatory medication, does that reduce Alzheimer's disease? And that work has really not brought anything to fruition. So we haven't proven that by giving Alzheimer's disease that you reduce.
I'm talking about more from a lifestyle point of view, diet, anti-inflammatory diet.
You see, I think, and I suppose the carotenoids and other interventions actually do have antioxidant, anti-inflammatory properties, and I can't specifically answer your question, but there's certainly something in it. Certainly something in it.
Question here? Mm-hmm. Yes.
How are you?
I was wondering about whether there are some. Thanks so much. Some people argue that visual impairment exacerbates the known memory impairments in Alzheimer's disease, so the presentation of their impairment is harmed by visual impairments. But in the studies you described using carotenoid supplementation, you could actually address that. You commented vision's better, but no change cognitively. So does that argue against the people who worry some of the deficits are really visual rather than memory?
Well, you know, visual impairment contributes to so many other things down the line. So falls and the outcome of falls have a huge impact on people with Alzheimer's disease. Reduction in vision, you know, in their ability to put on the cooker, to do their activities of daily living. So actually improving vision is a very real, very important part of the story, regardless of cognition, improving vision. The difficulty with the study that we've done so far, or our preliminary work, is that patients at an established or moderate time of Alzheimer's disease have established memory. So we know that have established cognition loss. Unfortunately, we know that at that point, any intervention is not going to bring that memory back. What you need to do is do the same study in people with mild cognitive impairment or pre-Alzheimer's, pre-symptomatic disease, to find out impacts on cognition. But the vision, improving vision is hugely important. It's just hugely important, both from a light, a depth perception point of view, from an everyday activities point of view, or from reducing falls. And you know, it is important to acknowledge it's not just vision and macular pigment. There is a processing of information to the occipital cortex, obviously, that's really important as well. But that's a really important clinical finding of that work.
Dr. Mulcahy, if I may, I'd like to ask a question too. Do you have any suggestions for preclinical markers for Alzheimer's that would be similar to drusen in AMD? So often grant reviewers will want us to have something specific like alpha amyloid or beta amyloid in the CSF, but that's not easy to do in many epidemiologic interventions. Are there memory tests or other things that you can think of?
Okay, I think unfortunately in the non-symptomatic stage, so in people in their 30s and 40s, there doesn't appear to be a clinical or a neuropsychological test that you can do at that point, because remember, people's cognition and function is normal. So maybe the way forward, certainly I know from an ethical approval point of view, we're not going to be allowed to take CSFs on thousands of people to try and identify markers, and there are markers in CSF. There is very interesting work being done by Mapstone et al., and I know he published in Nature a series of phospholipids in the serum that might be predictive of Alzheimer's disease. However, that work is being replicated here in Cambridge, and I know Professor Howard is actually looking at it as well, just to see, can we find serum biomarkers, because serum biomarkers would make it so much easier. I think looking at doing MRIs on people or PETs on people, that's just not realistic. It's both time-consuming and costly, and in epidemiological studies, they don't want that. So if we could have a simple serum test in time, that will help.
Thank you. Okay. So on. Thank you.